Well, hello and welcome to Healthline this Tuesday evening. I'm Jennifer Blomquist. I have the privilege of hosting the program tonight, and I'm so glad you joined us. We have a wonderful guest. She is new to Fort Wayne. She is new to our program. We're going to be talking about breast cancer, and she is the expert. She is the one to go to for this. So we're going to be talking about that and advances in treatment. It's a whole different ballpark out there when it comes to this horrible disease, but much better outcomes. So I want you to pay attention to the phone number. It's at the bottom of the screen, and we're going to keep it up for you there throughout the show. It's 969-2720. If you're outside of Fort Wayne, just put an 866 in front of there, and it will still be a free call. That is the way to get your questions answered. So call at any time. The doctor, who's our guest, will be, she and I will be talking throughout the program, but please call at any time and ask any question you may have related to breast cancer and surgery and treatments, anything like that. And then I want to remind people that you have two options when you call in. You can ask your question live. I like that better because then you can interact with the doctor one-on-one. Maybe she needs to ask you some questions to better answer, or give you a better answer. But if you don't feel comfortable doing that, I totally understand. When you talk to the call screener, who's a very nice lady, she can take your question for you, and then I can ask the doctor. So you have two choices, but like I said, it's kind of nice to be able to interact with the doctor. Well, let's go ahead and meet this wonderful guest. Like I said, she is new to our program, Dr. Patricia Clark. And this was a new word to me. You are a breast and oncoplastic surgeon.
Yes.
So we're gonna talk about what oncoplastic is, because I know I've written a lot of articles and things about breast cancer. We've done many programs on breast cancer, and that was a new term for me. But we're going to go over what that means in just a minute. So welcome.
Thank you.
Thanks so much for coming. And she is new to Fort Wayne too. So we two welcomes, I guess, new to the program,
That's
new
right.
to our community. You know, Dr. Clark, like I said, I've done so many articles over the years. I've been working in media for over 30 years, and I've written so much about breast cancer. And years ago, when you heard about somebody getting breast cancer, it was very scary. I mean, you just figured, okay, that person is probably not going to live much longer. You know, maybe they can just give them some treatments to buy them some time. And now, in the course of a week, every week, I am meeting women who are breast cancer survivors.
Yeah.
And they look great. And it's, you know, 10 years ago, 20 years ago. So it's a different scenario today.
It's completely different than it used to be, and it's one of the reasons I really enjoy taking care of breast cancer patients. We have about 4 million survivors in the U.S. now. It's just incredible.
Yeah.
So what's happened over the years is our surgical techniques have improved a lot. We have early detection now to where we're diagnosing cancers when they're very treatable before they've even spread to the lymph nodes.
Yeah.
And then one of the other things that we're doing is with the revolution in molecular genetics, we're getting really targeted therapies. And I have this admission. When I was a resident too many years ago to count, I didn't like breast cancer surgery. I didn't like breast surgery.
Really?
And I didn't like it because our surgeries were very disfiguring.
Oh.
And then everybody who had a 1 centimeter, which is about a half-inch size tumor, they all got chemotherapy.
Yeah.
Back then, to tell if there was cancer in the lymph nodes, we had to take all the lymph nodes out. People would get lymphedema of the arm, and it was just, it hurt my heart to do that. And what's happened since then is cancer is all a series of molecular genetic mutations that cause normal cells to go haywire. Right. And we are understanding things at that level now, and we're de-escalating treatment to where we don't do full axillary dissections routinely anymore. We don't give chemotherapy to people just because of the size of the tumor. Like, we go in and really precisely figure out who's actually going to benefit from that, whose tumors are that aggressive, and we do genetic testing right on the tumors that we take out to see if they have the mutations necessary to spread. And a lot of these tumors don't. So those people can avoid chemotherapy completely. So it's completely different. People come in and they're just really frightened. And
it's scary. It's a scary diagnosis to get, for sure. Even despite all these advances, it's very emotional.
Yeah.
But the one thing I know that has changed, and we've talked about this on this program before, is it's not just you know, you and one doctor here, and then you have another doctor treating this. It's you do a whole team.
Yeah.
And a team works together all the time to make sure everything is covered, which I've heard from a lot of patients that that's very comforting.
Yeah, and that's where we've really gone with breast cancer care, and frankly, all cancer care. With breast cancer, you actually have 3 different flavors of oncologists.
Oh,
you have
yeah.
surgical oncologists, there are radiation oncologists, there are medical oncologists, and then there are so many other team members like nurse navigators that help people through. There's psycho-oncology, exercise oncology, genetic counselors, just a huge team.
Yeah, that is, well, and there's so many components to it, you know, you've got the before, the surgery, and then the recovery.
That's right.
So since I promised everybody that I would tell them what this oncoplastic surgery is, so can you discuss, and this is what you specialize in?
I've sort of carved my career out with the oncoplastic aspect, and as I was telling you, when I first started doing surgery, I didn't like breast surgery because it was very disfiguring.
It used to be, yeah.
It really used to be, and now survival with lumpectomies and radiation is actually higher than survival with mastectomies. And oncoplastic surgery combines plastic surgery techniques to reconstruct lumpectomy defects so that you avoid those deformities or the divots or depressions. So people can actually come out after cancer center looking better than they did before. But
that was the one thing, because we've had, sadly, a lot of breast cancer on my husband's side of the family. It took his mom's life and a number of her sisters. And the one thing I heard from a lot of them was, you know, they're just saying they want to do this lumpectomy, but I just want the whole breast removed. I just want it gone. And they said, take the other one too. And you know, there was this has, you know, been in the last 10 to 15 years, but the surgeons were like, no, it's better just to do the lumpectomy. So can you talk about that? Because I think a lot of people think, let's just get rid of it, but then I've heard that's not the right way to go.
Well, and particularly the younger patients, it's such a frightening diagnosis that everybody's like, no, just, I want a double mastectomy. And if they look on social media, a lot of the people on social media, oh, I had a double and I found it in the other. That's actually very, very unusual.
Okay.
The risk of getting another cancer in either breast that's brand new, not a recurrence, is only about 3% a decade.
Oh, wow.
So so double mastectomies
low.
For that, you know, it's just there's not a good good return on that.
Yeah.
And then the other is the recurrence rate is only a couple percentage points lower for a mastectomy than it is for a lumpectomy.
All right.
But then the survival's higher with a lumpectomy. So I hear people, you know, they want to live for their children.
Sure.
Mastectomy is not going to do that. And the reason mastectomy doesn't do that is if somebody is going to have a lethal cancer, they metastasize. That metastasis may not show up for a couple years after the surgery. Okay. But if you think about it, if I did a lumpectomy and all the margins are negative and I got it all, or did a mastectomy, which we ensure that that's the case, those metastatic cells were already present at the time we did the surgery, and it just took that couple years for them to grow enough to become symptomatic enough that we found them. So it's just really important for breast cancer patients to know that, you know, mastectomy, survival's not the reason to get a mastectomy. And for people that don't have a genetic mutation that would predispose them, like Angelina Jolie.
That's what a lot of people hear, about the, you know, famous people and their experiences, and then they gravitate toward that. Yeah,
about 85% of people that get breast cancer don't even have a family history. So they're not at high risk of getting a second new breast cancer.
Well, there was that whole phase, with the BRCA, you know, wanting to do the genetic testing, and like I said, we've had a lot on my husband's side, and of course, all of his cousins and their daughters are nervous, but they've all been tested, and they haven't found it either, and they were sure that it was something because it's been so widespread in his family, but it doesn't exist.
Well, and there are some families that it's very widespread, and we'll test broad gene panels, maybe 60 to 80 genes, but there are some families that there's something going on there, but we don't know what gene that is.
Okay.
And it's interesting, there's a woman in Washington State who discovered the BRCA gene.
Yeah.
And she is collecting these patients with families that have
Okay.
huge family histories and we can't find anything. She's studying them.
I'll have to talk to you after
Yeah.
the show about that. Yeah,
Yeah.
because they're all, and I worry for my daughter too.
You bet.
You know, so. Well, we do have somebody who wanted to ask you a question, but wanted me to ask it for them. So Wesley called and wanted to know, how often do women have to go back in for a mammogram after, if something is found? So, and is that common? Is it something to worry about if they find maybe a little suspicious area, but it turns, you know, then do you have to go back more often than for the mammograms? Or?
Yes. So one of the downsides of the early detection of breast cancer is we are detecting very minute things that, you know, probably are nothing. And we follow those for 2 years typically.
Oh, okay.
Yeah, there's a rating scale on mammograms, and it's called a BI-RADS, and it goes from 1 to 6. 1 is pristine, which most people don't get.
I was wondering if anyone gets that. A score.
Rarely.
Okay.
2 is what most people get. 3 is where, there's something a little funny there. I think we should watch it. And they'll typically bring those people back every 6 months for an ultrasound or just a little extra. So when people get a BI-RADS 3, it's nothing to panic about.
Right.
A lot of times they're fibrocystic changes. And actually over half of women have dense breast tissue and can have some of those types of changes. So it's not panic time.
Well, you know, and I'm glad you're talking about the mammograms and the ultrasounds, because there was a lot of confusion for a while from some of the national, you know, programs or medical organizations where they were contradicting, maybe you don't have to have a mammogram every year after a certain age. I realize it's totally different if you have the family history.
Right.
My understanding is you go, you know, like if your mom had breast cancer at 50, you start or maybe even at, let's say 40, you would start your mammograms earlier than that.
About 10 years earlier.
Is it that much? Okay, I thought it was 5 years.
It's 10 years earlier than the youngest person, the age of the youngest diagnosis in the family.
And you would go every year at that point? Okay.
Yeah, and what had happened is the U.S. Preventative Task Force, they came out with recommendations to start mammograms at 50 and not get them every year.
And because it was 40, that was the standard forever. And
well,
then
they changed back.
Oh, they did? Okay, they have
this
now.
Yeah, this was so controversial, and the radiologists, the gynecologists, the breast surgeons, everybody said 40. And the Preventative Task Force, their concern was all the anxiety that these mammograms that have abnormalities on them are, or biopsies where we go and biopsy and we didn't find cancer. And women between 40 and 49 don't get cancer as often as women over 50. Okay. So they were looking at the bang for the buck. The problem is those women, the younger you are at diagnosis, the more likely you are to have a lethal cancer. Oh. So the cancers that women in their 70s get, a lot of times those are very slow growing, they're not particularly aggressive. The cancers that the very young women get, those are often very aggressive and those can be deadly. So that's why we want you to start at 40. Yeah.
Okay. So we'll just clear the air here tonight. So that is because I know my doctor said no, just keep going.
Yes.
Because I was already in my 40s when that whole thing came about. But so it's every year, and then like you said, you might have to go every 6 months and have an ultrasound if they see something suspicious.
Yeah, if they see something that they're not quite sure of, but it really doesn't look like, that's cancer, they'll just keep an eye on it. And then usually after about 2 years, they run out of worrying about it.
Okay.
And we actually have, there are other modalities. Some women are just exhausted because no matter what, their mammograms are always abnormal and they're always going back. One of the things that can be done now is you can get IV contrast with a mammogram.
Oh,
and it's almost, it's almost like getting an MRI and a mammogram at the same time. Yeah, those women that are just exhausted from having all these biopsies that turn out to be nothing and they're always getting called back. When we add the contrast to the mammogram, a lot of times that reduces all those callbacks and gets them back to a once-a-year schedule.
All right, good to know. Because, that's normally you would do the contrast with an MRI. So
Right.
that's, yeah, good information
Right.
to know. I just want to remind everybody that we only have Dr. Patricia Clark here for a little bit longer. We still have plenty of time to take your questions, but I'd hate for you to miss out on an opportunity to get something answered, maybe a concern about yourself or a loved one or a friend. So give us a call. It's 969-2720. Again, it's toll free if you're outside of Fort Wayne, as long as you put an 866 in front of there. They're showing me the cue cards. We have 10 minutes left, which is, in television, that's a long time, but relatively speaking. But like I said, please feel free to call. You can do what Wesley did and have me ask the question for you, or you can talk live to Dr. Clark. Your choice. We're going to keep talking, though, about this. In the notes you sent me, I was surprised when you were talking about trying to not have to do chemotherapy or radiation, which, I mean, I know surgery is not pleasant, but I mean, that always seems worse, you know, the losing your hair or just
Yes.
the side effects and the illness. I mean, and that's scary too. So that sounded really good to me, that you could maybe get by without doing chemo.
Yeah, and we assess every patient. This multidisciplinary assessment, we're assessing every patient to see what can we omit.
Okay.
You know, when I was talking about 20 years ago, we used to take everybody's lymph nodes to see if there's cancer in it. Now, women over 70, we don't routinely check lymph nodes at all. And
Okay.
before 70, we just do sentinel node biopsies, where we put a little dye right at the areola, usually once people are asleep, and it will track through the lymphatics, which are the first place that breast cancer cells tend to migrate.
Okay.
And if it's spread up into if it's likely to spread, it'll go to the lymph nodes first. So we just take out the lymph nodes that pick up the dye, which is usually 1 to 3.
Okay.
Because of that, those women only have about a 3% chance of getting lymphedema, so we don't have arm swelling problems with that.
Yeah.
And ductal carcinoma in situ is an interesting entity, and those are cancer cells that are still trapped just within the normal milk duct, so they can't
yeah.
even get out into the breast tissue. On the DCIS, when we do lumpectomies, traditionally all lumpectomies got radiation therapy, and you don't lose your hair from radiation. It's you go in for about 20 minutes to a half
Yeah.
hour once a day, and that's anywhere from 5 days up to 4 weeks. We can
Yeah.
start radiating just part of the breast, but with ductal carcinoma in situ, we can actually do genetic testing right on that disease and figure out if those people even need radiation at all with a lumpectomy.
Yeah.
And elderly women, we're starting to target some elderly women with these low risk tumors that even with a lumpectomy, they don't need radiation. So,
Yeah.
yeah.
No, it is amazing. My dad has a cousin who's in her early 80s, and she's had breast cancer this past year. You would never know it. She looks great, you know, but yeah, like you're saying, everything's been so precise and minimally invasive.
Yeah.
She does not look like, I figured she would look really worn out, or she looks great, and she's still kind of living her life, you know,
Yeah.
doing her normal activities. I mean, dealing with her illness, of course. But
Yeah. Yeah, the goal is to restore people back to their, as much as possible, to their pre-diagnosis state.
Yeah.
So you want them to have the energy level. Survival has been going up by about 1% a year, every year for a
pretty
decade.
good, yeah.
It's
That's
really
really
good.
good.
Yeah, so people are going to live 30 more years after their breast cancer
Yeah.
diagnosis. So we don't want to do something, particularly in the elderly women, we don't
Right.
want to do something that you know, they've got a quality of life, and now we've been too aggressive, treat the cancer, but we've destroyed the rest of their quality of life. Like,
Yeah.
you don't want to do that either.
Right.
So it's really, really individualized for each patient. And one of the things with the patients will come in and they'll say, "What would you do, doctor?"
Yeah.
I don't know what I would personally do.
Yeah.
And they'll want me to make the decision, lumpectomy or mastectomy, that type thing. When it doesn't, when the patients understand the parameters I explained, they have a choice. And there are some patients that will never get a restful night of sleep for the rest of their life if they don't do a double mastectomy.
Yeah.
Okay, you can't leave somebody that way either.
Yeah.
It really is a choice. But yeah, patients have to go through a little sweat in the beginning while
Yes.
we have a shared decision making here.
Oh, yeah.
So yeah, it used to be the surgeon would just say, this is what
This
you're
is
going
what
to
you're
do.
going to do,
And
yeah.
it's like, no, we have treatments that may be equivalent, or there may be one advantage here and a different advantage there, and patients need to kind of weigh their own feelings about their breasts and which one of those pluses and minuses are more important to them.
I agree. I mean, there's no cookie cutter. Everyone's got their own, style, their own priorities, so I can understand that.
Everybody has their own relationship with their body too, and with mastectomies, you can, like a lot of people are going flat now. You can do implants.
Okay.
One
I've
of the
heard of
things,
that.
one of my favorite mastectomy reconstructions is called a deep flap. And that's where you take the abdominal tissue you would throw away in a tummy tuck.
Yeah.
You can take that and you can fashion new breasts from that. And those are soft, they're warm, they'll last for 30, 40 years without needing a revision. That's a great surgery.
Yeah.
It's an all-day surgery.
I actually know a friend from church who's going to have that this January. Yeah. And so, but yeah, it's just, and again, she hasn't really missed a beat either,
No.
I mean, going through some major surgeries, and she's going to have this reconstructive procedure done. So
There are just a lot of options now.
which is wonderful. We did have another gentleman. The guys are calling in. Good for you guys. They're calling in tonight with questions. So Rick wanted to ask, should men self-check for breast cancer? Can breast cancer be more aggressive in men? We don't really talk about that very much, but
Yeah, men should absolutely self-test, and particularly men who have family histories of breast cancer.
whether it be in women or men, like
Yeah, well,
even
if
if
they
it was
have-
your mom or
Yeah, and the younger at diagnosis that person with the family history is, the more suspicious that is that there might be a genetic mutation causing it.
Okay.
So breast cancer in men is fairly rare, but we usually diagnose it later because men they're not checking their breasts.
Right.
And when men get breast cancer, I think they're a little bit more likely to have one of these genetic mutations like the BRCA gene that Angelina Jolie had.
Yeah.
Those are more aggressive cancers. So, we want to catch the male cancers early.
And I mean, do they still recommend women do the monthly self-checks? I mean, that was a big thing in the 80s, and then I've had some doctors come on the show and say, well, we'd rather just have you come do the mammogram once a year. But
So you should still do the self-checks. There's some controversy and differing literature on how effective that is. The thing about the mammogram is if you're trying to detect a tumor by just palpating it, you're probably not going to be able to tell anything less than a centimeter.
Okay.
And if somebody's breasts are really large, for sure they're not going to find something really small buried in there.
Yeah.
So the mammograms give us the ability to detect these very, very tiny tumors that, those are just simple same-day outpatient surgeries. Most people don't need anything stronger than Tylenol after having breast cancer surgery these days.
yeah, that is amazing too, because that used to be like a week-long hospital stay, and it's not.
Well, even our
anymore.
mastectomies go home now.
Oh, do
And
they?
Yeah, we
Okay,
have
same day?
Same day.
Wow.
We have
okay.
advanced recovery protocols where we pre-medicate people before surgery. They're taking Tylenol. They're taking anti-inflammatories, and then with the mastectomies, we'll even do nerve blocks, so the whole chest is numb before we ever make an incision.
Okay.
So they don't have to bring people as deep under anesthetic as they used to.
well, that's
So
nice.
people don't have a lot of the post-op nausea, vomiting. The energy levels
Yeah.
are higher. So with all the blocks and the other medications, it really drops the narcotic needs.
Yeah.
So I'm not saying it's a walk in the park. Don't get me wrong, but it's just a completely different ballgame than it was even 10 years ago.
Oh yeah, no, it's amazing, and we've got somebody. I'm not sure if we're gonna have time to squeeze this in, but somebody was asking a quick question. A woman named Connie said she went in for a regular exam, nothing showed up. 3 months later, she was told she had estrogen breast cancer.
That's unusual.
Is that? Yeah, she was
So-
wondering if that was common or not, but it's
Now,
not.
the estrogen positive breast cancers are the most common type, and they're generally pretty slow growing.
Okay.
So, and I have seen somebody pop up in 3 months. There's a subclassification of estrogen-positive tumors that actually are very aggressive and act a little bit more like the triple negative or the HER2/neu positive ones. Also, somebody with extreme breast density, there may be other confounders that when you go back and look at that mammogram, you know, it might have been there and it just was sort of lost in the chaff of other things to where it wasn't picked out. But that is fortunately very unusual.
Very unusual.
And the one thing that's not unusual is lobular carcinoma. And the invasive lobular carcinomas are very patchy, and those are the ones that don't show up on the mammograms. They're sneaky.
Right. Good information. I hate it that the show is over. This has been a joy. You have got to come back. So she's brand new to Fort Wayne, so we'd love to have you back in the program anytime.
Love to come back.
Dr. Patricia Clark, thank you so much. Take care. Have a wonderful Christmas. Hey, this is my last show until the end of the year. So have a great Christmas. Take care. We'll see you in the new year. Bye-bye.
Program on PBS Fort Wayne was made possible in part by
momentum, progress, innovation. Parkview Health knows standing still isn't an option. We must learn, grow, excel, and actively work to advance healthcare for our community and beyond. With technologies that improve access to care and teams of specialized providers, we are moving healthcare forward. Right here at Parkview Health.